Bronx Heart Grind Rounds at Montefiore Einstein. It is a true pleasure today for me to introduce Professor Mandeep Mehra from the Brigham at Harvard Medical School. I would just give a brief introduction because otherwise there will be not enough time for the talk. He currently is the William Harvey Chair in Advanced Cardiovascular Medicine and also the Executive Director of the Center for Advanced Heart Disease at the Brigham in Boston. There are many accolades, of which I just would like to mention three. Number one, he is the immediate past editor of the Journal of Heart and Lung Transplantation. And under his reign, this journal rose to be the #1 journal in cardiac transplantation in the world, which was an incredible achievement that we all witnessed closely as members of the ISHLT. He is the only individual to have been both president of the International Society of Heart and Lung Transplantation, as well as the Heart Failure Society of America, the two premier heart failure organizations in the world. I also would like to say on a personal level that I've known Mandeep for maybe a decade or two now, and he is a true intellectual. I will say that the discussions that I was privileged to have with him and others, including our own Danny Goldstein, surrounding the momentum trial results when we were planning the publications are definitely, I count it as an intellectual highlight of my own career. So, but I don't want to take up his time. I just want to ask the obvious question after this introduction, are we worthy? So I would like to say that today we completed 2 lung transplants. We're about to do our second heart transplants of the day. And to honor Dr. Mehra, we also, Dr. Goldstein, about 2 hours ago, explanted a left ventricular assist device in a young woman whose myocardial function has returned. So no pressure, Mandeep. We're really happy to have you here. And please go ahead to give us one of your exceptional lectures.
Uli, thank you so much for that exceptional introduction. And I'm so appreciative because I consider you a friend, an intellectual colleague. Danny and you have been extraordinary in my academic career and my life. And I consider you as my journey partners. I also remember that you were kind enough to come to the Brigham and attend a ceremony when I was installed as the incumbent William Harvey Chair. And I will always remember that in my life. Uli, I know you were very busy that day. You took a plane ride in and a plane ride out that very day. I'm very appreciative for your friendship and your kind words, and also for the fact that you have occasionally trusted us by sending your fellows to train at the Brigham. And have even accepted them back, which I consider to be perhaps the most pinnacle achievement of my career, because people send people to other places and then they close the doors on them. But you didn't do that with Dr. Madan, who I hope is doing well, and I'm sure he is. Yes. So thank you for that. And, you know, in fact, that has opened doors. Now, one of our core cardiology fellows is from Montefiore as well, Monica Yamdamal, and she is absolutely exceptional in the same lineage as Shivank and what I've known to recognize from you. So, so we are actually in a mutual admiration society, is what I would say, Uli. And thank you for everything that you do in partnership with us academically. Well, my goal today is really a simple one. It is not to teach you anything new, but perhaps to help open the lines of communication for us to appreciate and understand the concepts that oversee myocardial recovery. And in order to do that, we have to, in fact, begin by understanding myocardial remodeling and that entire historical interface, which I hope will allow us to develop several questions. If we have developed several questions at the end of this conversation, then I will consider my talk to have been successful. Now, the first use of the term ventricular remodeling actually dates back to a paper in Circulation from 1982 by Judith Hochman and Bernadine Haley, two names that you will recognize. And in that paper, the statement where this term is first introduced states as follows. It says, if early thinning and dilatation did not occur after myocardial infarction, the process of remodeling with resorption of necrotic tissue, laying down of granulation tissue and scar formation would probably result in a healed area that was somewhat thinned, but generally preserved in normal LV contour. Now, what's important to recognize about this term is that this term was used in the correct connotation of a positive aspect to remodeling, not in a negative aspect as we have started to consider this. Whenever we say there's ventricular remodeling, we immediately consider it adverse, whereas it was not really intended for that. And when you remodel your home, when you remodel your kitchen, when you remodel your bathroom, it's for improving it, not for making it worse. Where did the term move towards a more adverse connotation? Well, we can implicate my colleagues at the Brigham, the two Pfeffers, Janice and Mark, along with Dr. Braunwald, who wrote this extraordinary paper in a rat LAD ligation model. And this was entitled Progressive Ventricular Remodeling in a Rat with Myocardial Infarction. So right there you have, and in the title, a negative connotation. But there were four critical aspects to this animal research that this paper opened for us. And I'm going to go over each of those four because this is critical for you to know that a simple study done outside of humans can be interpreted in such a manner as to develop an entire new field. The first critical point that was made in this American Journal of Physiology paper was that the structural remodeling of the left ventricle after an MI is a time-dependent process involving both the region of necrosis and the residual normal myocardium. This is a very important point. The second point made in this is that in the very early period of necrosis, edema, and vascular congestion, left ventricular dilatation may take place as a result of infarct expansion. But this is a very important point, that this early infarct expansion is a useless infarct expansion. It provides no mechanical advantage to the impaired ventricle. The third is that during the formation of a discrete thin scar, marked increases in volume occur in the cavity, and the intention of that is to restore stroke volume. This is a very critical physiologic principle. And then in the more chronic phase post-infarction, volume enlargement may continue as a deleterious event out of proportion to the mass change. And they also state in this paper that the degree to which the heart enlarges after myocardial infarction may have important implications for survival. So there you go. In one paper, in a rat study in 1991, these individuals, in fact, encapsulated the entire field of how we understand ventricular remodeling, with the only caveat that they gave it a negative connotation. Well, if we were to think about the remodeling interactome, the remodeling interactome consists of 5 very key components of changes. And these are changes that occur in all of these 5 areas. There are cellular changes, of course. There are changes to cellular cell loss. There's collagen matrix destruction. There's a change in geometry. Then there's a change in the extracellular matrix, where you actually see a different scaffolding being laid out in the heart. You then see changes in gene expression that revert to a fetal gene expression phenotype. And you also see the upregulation of neurohormonal systems, which are then part and parcel of the principal change of an energy, metabolic, and oxidative stress and inflammatory milieu, which encapsulates the 5 key areas of adverse remodeling. But if you had to even simplify all of that, the key is that adverse cardiac remodeling is really an altered energy state for the heart. It's an energy deficit. And in fact, when you look at the cellular level, there is an increase in glucose oxidation with decreased free fatty acid oxidation and a consequent lipotoxicity and mitochondrial dysfunction. So if you had to even simplify it further, you would say that what happens as a result of the injury is that these pathways promote necroptosis. So there's necrosis and apoptosis, all participating in unity. Now, of course, one of the most critical things that happened in 1992 was the translation of the concepts that were being built from animal models to humans. And this is the sentinel trial called the SAVE trial, the Survival and Ventricular Enlargement trial, which Mark Pfeffer and Gene Braunwald led. And this trial, which really ushered in post-infarction use of ACE inhibitors, showed that this drug could reduce death due to any cause in post-MI patients, and that it did so also while preventing new ischemic events, and it did so while reducing the incidence of heart failure requiring hospitalization. So one of the most important translational aspects that moved from the animal model to cellular understanding to the clinical model. So if we have to think about remodeling and the whole emerging concept of myocardial recovery, one has to think about it from three possible pathway outcomes. And when you think about reversal of this adverse remodeling, there are three things that can happen. The first is that you may slow or arrest adverse remodeling. And where's the evidence for that? The evidence is in thrombolysis in acute myocardial infarction. So thrombolysis saves lives, but not necessarily to the same extent as restoring the circulation with intervention. And one actually sees that there is attenuation of the remodeling. So there's slowing. And we see the same effect with exercise or cardiac rehabilitation in the literature. Where you then transition to promoting reverse remodeling, and in a modest way, you see the pharmacological pathway, the neurohormonal pathway, facilitating that with different gradations, and we'll discuss that in a bit. And then you, of course, have interventions such as with mitral valve repair or cardiac resynchronization therapy. And then people have taken this to the step and saying, look, if we can just support these ventricles completely and facilitate a hemodynamic unloading, or perhaps surgically reconstruct them, we might in fact be able to normalize the structure and function. And therein has come this entire concept of myocardial recovery, in which your group, the Montefiore group, has had a long-standing interest and great contributions in the field for decades now. There are some unique situations from which we can learn where there is an acute injury into true recovery. And it is really critical for us to understand the difference between true recovery and partial recovery states from a nomenclature standpoint. Now, what are the effects of pharmacological therapy on myocardial structural improvement? If you had to look at the literature carefully, the first point is that about 20% of people will reach the point of a full recovery, defined as people who normalize their ejection fraction and their lung and their heart volumes. The more common phenomenon that you see in the other 80% is that incremental therapy, as you stack it on pharmacologically, will provide greater and greater opportunity for remission of this particular issue. For example, ACE inhibitors provide somewhere between a 1 to 3 to 4% improvement in ejection fraction. Beta blockers on top of that, another 5 to 10% improvement in ejection fraction. Aldosterone receptor antagonists on top of that, another 2 or 3%. And now we have data with ARNIs, or angiotensin receptor blocker neprilysin inhibitor drugs like Entresto, that show that these drugs can provide even more incremental improvement in structural remodeling and left ventricular ejection fraction. This is data that Jim Januzzi and colleagues published from the PRIME database that actually took a group of patients who were not receiving ACE or ARB at baseline and had generally new onset heart failure. And these patients were then treated with an angiotensin receptor neprilysin inhibitor, a few of them. And this data segregates them out. When you look at the yes rows here, that's the group that we're talking about. And in those patients who have not yet been exposed to ACE or ARB at baseline, the use of ARNIs can give about a 12 to 13% improvement in ejection fraction by 1 year. What's important to note here is that the remodeling is not isolated to the ventricle. In fact, one of the key things to keep in mind is that the atrium and the atrial remodeling also occurs, as shown here on the last row here with left atrial volume index, where the left atrial volumes also start to decrease. Another important point to be made is that 6 months may be too short a time to see the end benefit, and that this is a process that takes time and needs to be followed out to at least 12 months before you pass judgment one way or another in patients in terms of ventricular remodeling. Now, of course, the latest kid on the block is an SGLT2 inhibitor. And while we have seen great clinical outcomes data with that, we have very little data on left ventricular remodeling and myocardial recovery with that. This is one such data point in a trial dubbed the Sugar Diabetes Mellitus HF trial. This was a small study that showed that the use of an SGLT2 inhibitor does decrease volume. It does change longitudinal strain, but it does not impact left ventricular ejection fraction considerably. And this is important to note, which then goes to the point of how do these drugs really work. And we know that SGLT2 inhibitors are probably more akin to metabolic modulators. They have a number of systemic effects, of course, but as you think about SGLT2 inhibitors, you should not think of them as neurohormonal agents. I don't think there's anything neuro or hormonal about those agents. They may have effects on the sympathetic nervous system, but many of these effects might be secondary and not primary. On the other hand, what has been shown is that cardiac specific effects, which result in a reduction in left ventricular mass, in particular with these agents, in people of untreated diabetics in particular, it shows that what these drugs do in those patients is that they actually change the metabolic modulation at a mitochondrial level and in oxidative metabolism, where there is a shift in the generation of cardiac energy or the generation of ATP, and the production is changed relative to the untreated diabetic hearts in terms of what happens to ketone oxidation, glucose oxidation, and fatty acid oxidation. So fatty acid oxidation decreases, and there's a switch to predominant glucose oxidation, and this allows the generation of more ATP so that the energy starved status within the heart is reduced. And perhaps that's why you see some of the benefits, either from an arrhythmia reduction standpoint or in reduction in LV mass. You don't necessarily see a positive inotropic effect, as an example. So the next question is, are these the best pathways to attack through neurohormones, cytokines, and growth factors? And what do we know about facilitated hemodynamic unloading with mechanical stretch addressal on one side? How do we actually think through that concept, and what have we learned so far, and where are we going with this? So for this, I'd like to invoke an old physics principle that was proposed by Pierre Simon Laplace, and I prefer to call this Laplace therapeutics. Much of what we practice in advanced heart failure surgery is really addressing that mechanical stretch pathway. And with Laplace therapies, as Dr. Jordi pointed out, you've done a few of those today where you have invoked Laplace therapeutics at the very extreme by completely taking out a dysfunctional heart and putting a new one in, or you have invoked it at the other extreme where you have decided to explant a left ventricular assist device and allow the heart to maintain its circulatory status on its own. And if one were to think through Laplace therapeutics, one has to invoke Laplace's law, which is a stress-strain relationship that really posits that the stress or strain encountered within a cavity is directly proportional to the pressure exerted in that cavity. It's directly proportional to the size of that cavity, the diameter, and it's inversely proportional to how thick the wall of that cavity is and how much buffering effect that wall can provide. And in that regard, there have been a number of different ways of treating this, and what have failed to really show a remarkable benefit is remodeling surgery or the use of passive restraints like with the Acorn device, or with the use of reducing the ventricle into a bi-fit ventricle, such as with devices called the myosplint. And we don't have time to go into that gory procedure, but it is what it is. On the other hand, the best way to decrease pressure and decrease strain is with a left ventricular assist device. And in fact, of all of the things that are depicted on this, including cell therapy, which is designed to really increase wall thickness regionally to mitigate scar, one has to admit that of this, the only therapy that has been clearly shown to reduce the mortality is the use of a ventricular assist device. And that is the key point of Laplace therapeutics, is that you have to decrease the pressure if you really want to change life. Now, as we think through this, you have to, in fact, think about a few concepts. And a few concepts relate to the difference mechanically between elasticity and plasticity. What do I mean by that? If you were to look at this image that I'm showing you now of this woman who is practicing advanced yoga, and it's got to be advanced yoga because very few of us can really do this. If I were to ask you, what's the chance that this woman will not be able to come out of this particular posture, you would laugh at me. You would say, no, of course, as soon as she releases her hands and her legs, she'll normalize and go about and walk around. So that is very elastic of her. And in fact, this is the concept of elasticity, where if you deform something, it can in fact reform itself without any residual deformation. That's the difference between elasticity and plasticity. So said another way, if you had a rubber band, you know that if you increase the size of the rubber band and you then release it, it will snap right back in its elastic configuration and it will still be usable. If you use a paper clip and you deform the paper clip and then you physically reform it, it will still function as a paper clip, but it will never lose its deformation memory. And the point, of course, is that, there is an elastic region and then there is a plastic region. And this is true for almost any material, including the myocardium and including a scarred out myocardium, where it reaches its elastic limit. The point being that if you get to invoke ventricular remodeling too late, in the plastic region, you need to use mechanical unloading and decrease pressure. Whereas in the elastic region, it may be much more effective to use pharmacological therapy because its intrinsic deformation characteristic is still not visible. And of course, death in our terms is when the plastic region is reached beyond its limit to a fracture. Now, Doug Mann and Dan Burkhoff and others have very nicely shown us how to think through the construct of ventricular remodeling. And shown in this encapsulated diagram, which I really appreciate, are a number of different myocardial insults, whether it's a toxic insult or an insult on abnormal energetics or on inflammation or across neurohormonal activation or in hemodynamic overload. And the key concept to keep in mind is that those components that are a result of abnormal energetics can in general be restored without invoking deformation memory in the heart. Whereas if you have toxic insults or you have chronic hemodynamic overload, in those cases, completely reversing the deformation memory is unlikely. And this is why we see what we see in patients on advanced heart failure on left ventricular assist device support, where if you look at clinical studies, the clinical evolution to explantation is very few. In fact, the most recent data from our registries of unsupervised explantation suggests that it's less than 5% at 4 years. Structural and functional remodeling occurs in about a third to half of the patients that we see. So you'll see improvements in ventricular decompression, improvements in ejection fraction, improvements in the shape of the heart. And at a cellular level, you tend to have paper after paper showing evidence of recovery. So even though we have evidence of cellular recovery, what happens in patients with advanced heart failure is that their heart, its biomaterial, if you will, has transitioned to such an elastic point, to a plastic point, that it cannot overcome its complete deformation memory. And there are so many lessons for us to learn from the LVAD supported literature that can inform us in understanding how remodeling occurs. And I'd like to share some of those concepts with you. So question and concept number one is, does the recovered heart retain its phenotype deformation memory? Just, is it like a paper clip? Why is it retaining its memory? Where's the memory coming from in that? Now, why is it staying deformed? Well, before we go into that, we should look at this particular trial, which is a very important trial, and I hope we have a chance to discuss it. It's an example of a trial that can be done in just 50 patients, but if it's well constructed, it can be extraordinarily informative for us. And this is called the TREAD-HF trial that Brian Halliday and his group published in the Lancet a couple of years ago. In this trial, they took patients with heart failure and reduced ejection fraction who on clinical therapy and pharmacological therapy had all recovered to a left ventricular ejection fraction that was considered to be in the normal range with normal ventricular volumes and normalization of their NT-proBNP levels to under 250 nanograms per liter. And what they did is they first started by weaning off they randomized them to weaning off diuretics first, and most of them successfully got off diuretics because they probably didn't need decongestion anymore, as evidenced by the proBNP levels. And then they started a staged withdrawal of pharmacological therapy. And lo and behold, by 6 months, nearly half of them had all relapsed. Their ejection fractions started to decline, and they relapsed, indicating that there was deformation memory that was pharmacologically responsive in those patients that existed in each of these hearts, even though they appeared to you and I as having completely recovered and completely normalized. And in fact, 40% of these patients still had scar or late gadolinium enhancement on their CMRs. When they tried to look at predictors of relapse, the thing that came up in a 50-patient study, it's hard to really analyze subgroups, but be it as it may, they suggested that the older you were or the more aged your cells were, the more heart failure meds you required and for longer periods of time, or the higher, even in the normal range, the higher your expression of natriuretic peptides were, or the more global radial strain you had, the greater was the chance that you would relapse. But what was strange was that the presence of late gadolinium enhancement or even familial history of genetic cardiomyopathy were not predictive. there were some people with late gadolinium enhancement or familial cardiomyopathy who actually stayed fine after they were taken off meds, indicating that there is marked inter-individual variability of such a response. And it indicates that the heart somehow retains its cellular memory. Have we learned anything about this from LVAD-supported mechanically facilitated unloading? And I would say that before we go into that discussion, we need to think about the next question. That is there a threshold effect to recovery or remission? And I'll go into this. In other words, is there such a time point in the stage of heart failure where even after you enter into the plastic region, that you are so close to the fracture point that there is very little point in recovery? The best way to learn a lesson from that is to look at what we've learned from secondary mitral regurgitation. And we know that secondary mitral regurgitation, which we don't really have time to go into the details of, is really a ventricular disease and an atrial disease. And it's a combination between the atrium and the ventricle that ultimately determine the onset and genesis and development and prognostic implications of chronic secondary mitral regurgitation. What can we learn from that? Well, we've learned a lot by looking at transcatheter edge-to-edge mitral valve repair in these patients. And you're probably already familiar with this data, and we're not going to go into the details except to use them in the context of the discussion of ventricular remodeling. We have two trials. We have the COAPT trial, and we have the MITRA-FR trial. And the MITRA-FR trial presumably looked at patients with advanced heart failure, showed no difference in 2-year survival. And the COAPT trial looked at similar looking patients, except who were treated with guideline mandated medical therapy, optimized on that, and then had residual significant mitral regurgitation, and it showed a survival benefit. How do we reconcile that? And can we learn something about ventricular remodeling from that? One way of looking at this is to take the patients within the COAPT trial who most closely resembled the patients in the MITRA-FR trial and see if you can replicate that particular finding. And it turns out that you can. It turns out that if you take patients who had more modest mitral regurgitation but had much larger left ventricular end diastolic volume index, that those patients don't appear to have the same survival benefit as the patients who have a much lesser left ventricular end diastolic volume index for the degree of mitral regurgitation. And it's those patients that benefit. Well, on Bayesian grounds, the question is, how common are those patients? And if you look at the enrollment in the COAPT trial, it took a lot of years across the 60+ centers. The average enrollment of patients was about 1.74 per year per center in that trial, indicating that if you went to someone at your center, an experienced advanced heart failure center, that if you were to truly move to the criteria that would allow enrollment into COAPT, it would be just a few of the patients that you see in an annualized basis. And that's the key problem with this, is that it seems that in COAPT, there was a group of patients who still had the opportunity to be at the threshold closer to the elastic region than the fracture point in the plasticity region, whereas in MITRA-FR, that was not the case. So this does say that there is a threshold effect to how quickly you need to get to these patients. And perhaps with left ventricular assist devices, there is such a thing as implanting the devices too late in the wrong population. So what are the clues that we can get to enhance our understanding of ventricular remodeling to some extent? Now, the first point, which I've already made for you, is that in an unsupervised setting, if you take a registry like the Intermax registry, the incidence of random recovery is about 2% at 2 years and 4% at 4 years. So this is in an unsupervised setting. And the question is why? Well, the most easiest answer that confronts us is that, hey, the L in LVAD stands for the left ventricle. You're only supporting one ventricle. So, and you're in fact imposing greater hemodynamic stress with increasing preload, creating septal dyssynchrony on the right side. And in fact, the tricuspid valve coaptation point changes with the way in which you establish an unnatural circulation. So quite clearly, you have a situation of what I would call a partitioned circulation, where you have unloaded one ventricle and loaded the other ventricle. And in fact, you may have stimulated the occurrence of a remodeling-based heart failure memory and the phenotypic memory in the unsupported ventricle. Is there evidence of that from cellular data? And there is. If you look at work that was published quite some time back by Ken Margulis and his group at Penn, it actually appears that if you look at the sum total of dysregulated genes, 95% of dysregulated genes do not revert back to normal after LVAD support. And I think it's because the cellular phenotypic and genotypic memory is retained for the deformation in these hearts. The second interesting point that we have learned is that the extracellular matrix can go in almost any direction. The scaffolding of the heart, the extracellular matrix, is so critical for mechanical efficiency of contractility. So it gets worse, it may get better, or it doesn't do anything. And so that may actually relate to whether there's a dose effect. That is, that the amount of unloading with a left ventricular assist device might be critical for us to think about. And then there might be the need to address things at a different level, perhaps at the microRNA level, or perhaps at looking at non-coding segments of RNA, or perhaps looking at other cellular targets for recovery, such as integrins. Integrins are signaling pathways that connect, say, the extracellular matrix to the myocytes. And you need proper crosstalk between all elements of the heart in order to achieve successful overcoming of persistent deformation memory in that particular cellular construct. Another problem that we have with left ventricular assist device support, other than the unsupported ventricle, is the unsupported coronary circulation. The way in which we place these devices, where the outflow goes above the coronary ostia, suggests that unless there is adequate washout, one is not going to perfuse the coronaries equally. And in fact, in animal studies, it has been shown that when you look at the flow on continuous flow LVAD pumps on the left ventricular, on the LAD, for example, the LAD mimics a chronic total occlusion almost in these patients. And one actually is fooled into thinking that these are ischemic coronaries when in fact they're not. And we actually did a study. One of our fellows did this study several years ago, where we did nuclear SPECT imaging in stable patients, all with dilated cardiomyopathy, and took these to a nuclear cardiologist and said, can you tell us if this is dilated or ischemic? And they said, oh, this is ischemic, this is ischemic, this is ischemic. So it's really indistinguishable. And if we don't pay attention to the coronaries, of course, what lesson does this teach us for the overall remodeling literature? The lesson is that the people with preservation in microvascular function and in epicardial flow are most likely to be those who will transition back to their native elastic region rather than stay in the plastic zone. Another important point to think about is the cardiac apex. And when we place left ventricular assist devices, our wonderful surgeons core out the apex and send it to the pathologist to look at. Well, it turns out that the apex is actually skeletally one of the most important components of the heart. And in fact, I think that the apex is probably the most important part of the left ventricle. Why do I think that? Well, first, if you look at it anatomically, for some reason, evolution has given it multiple circulations. Whenever something is given multiple circulations from the right and the left side, you have to pay attention to that on an evolutionary basis, somebody wants to protect this region by giving it redundancy. That's number one. Number two, when you look at the pathology, the cardiac skeleton, in fact, wraps around the apex, and it's the primary reason of a mechanically efficient twist function. And in fact, the apex is critical for the untwisting, which is probably the most important vortex function in diastole that we ignore. And so by destroying the apex, we in fact turn and destroy probably a small but a critical portion of our cardiac real estate. Now, can we get insight from other evolutionary mechanisms? And I have been thinking about this for some time with the Takotsubo syndrome. You know, you have this syndrome where you can have an emotional trigger and you can have a physical trigger. And shown here on your left is the fact that Takotsubo can occur due to any variety of distress signals, right? It's almost like a fight or flight response. And the question is what we see with the Takotsubo syndrome, where the apex selectively balloons, an attempt of the heart at protecting the apex by inculcating almost immediate acute hibernation. Just as we see with ischemic signals, we actually see hibernating myocardium that then comes back with revascularization once you restore the circulation. Is Takotsubo a mechanism built in general to protect? It of course hurts some people, but it might be that if this mechanism didn't exist, you would actually see a lot more persistent heart failure in these patients as a result of emotional and environmental triggers. What do we know about this very unique issue of the apex? Well, there is a concept called stimulus trafficking that you may be aware of. And that is that the density of the beta-1 and beta-2 receptors are different at the base of the heart and at the apex of the heart. And in fact, you have a predominance of available beta-2 receptors. At the base, at the basal area, you have a lot of beta-2 receptors, but they actually exist within granules in alveoli. And when they exist in that, they do not allow themselves to be fully exposed to circulating catecholamines. What happens is that with epinephrine surges, in low doses of epinephrine, it acts as a positive inotrope. But if you actually give someone too much epinephrine and you continue to give them that physical stress, that in those patients, the epinephrine actually converts itself into a negative inotropic signal, and it becomes anti-apoptotic. And if you look at some of the important research done in understanding the cellular biology of Takotsubo, you may realize that not only is it a mechanically important area for the cardiac skeleton, it is also a cellularly important area that is used for protection of the heart in preventing heart failure in the future. It's a theory, it's speculation. Hopefully we can discuss this. Another problem with left ventricular assist device therapy is that if we overdose the flow across the left ventricular assist device, we in fact allow the raphe of the aortic valve to fuse. And we create a new pathology in aortic insufficiency in these patients. And certainly that is not conducive to recovery if you're creating new, epidemiologically new valvular heart disease. You can't do that. So here's data from a hemodynamic modeling that suggests that there is such a thing as overdosing the unloading. And if you overdose it, you might not load the heart enough to where it's deconditioned. It's almost like telling you, look, just eat in bed, don't get out of bed for 2 months. And if you survive it from not having a deep vein thrombosis, well, more power to you. And then let's see how quickly you get out of bed after that. Well, we may be doing the same thing to these hearts, and it's worth discussing that point as well. Now, we have a trial that Dr. Jordi and Goldstein and others in your group were pivotally engaged in, called the ReStage trial. I consider this to be a very, very important effort on our collective parts as a community. And these are patients in whom you're giving them a chance for explantation after they are placed on a left ventricular assist device, because nobody wants to stay attached to a left ventricular assist device if they can avoid it. And what this trial suggested are a few important points, just as we've discussed. First of all, it takes time to see structural remodeling and the opportunity for removal, even after mechanical unloading on pharmacological support. The second important point is that the success rate, even in well-selected patients, was about 40% in this particular trial. Now, what's interesting about this trial is that predominantly this trial enrolled non-ischemics with new onset or recent onset heart failure under the age of 60, and I'll show you what the average age was ultimately enrolled in just about 40 patients. And in restage, if you look, the age of the patients enrolled was 35 years. Again, on Bayesian probability standpoint, if you think about all the patients that you refer for an LVAD, this particular age group would probably be a very small proportion of that group. The second interesting thing is that if you look at the early Harefield 10-year experience, which was what really pushed the field forward, even in those patients, the average age of the enrollees was about 35, 36 in those patients. If you look then at real-world implants, whether they're from the endurance trial or the Momentum 3, HeartMate 3 trial, the average age is about twofold higher than what was enrolled in these trials, suggesting that this concept is clearly viable, but it's viable for a smaller Bayesian probability group of patients. And it's important to keep that in mind. Now, there's, of course, a future in recovery and regeneration, and who knows where this will go. This is just a schematic saying that maybe we have to think beyond in those people who have already reached the near fracture zone. We have to actually probably decellularize hearts and recellularize them through autologous transplant. Maybe that's the way to do it, and clone chimeric organs separate from the individual and then transplant them. Who knows where the field will go? But the point of this discussion was to understand these different phases and how to expect the outcomes in these patients. Well, some people have used bolstered facilitation, saying that maybe LVAD therapy is not sufficient. You need to add cellular therapy with mesenchymal stem cells. And this small trial, which was quite well done and only looked at surrogate outcomes of ventricular remodeling without actually explanting, showed that whether you gave stem cells or not, the change in left ventricular geometry was no different in these patients, suggesting that we still have a long way to go in thinking about bolstered facilitation using cellular therapy. So the point is that the science in this area, as I end my discussion with you, is evolving. It's important. There are many areas that we should be thinking about. It's not as simplistic as just giving a drug and then adding a hemodynamic unloading to it. There is a lot more to the science and translational discovery that we need to think about. And we should really focus our efforts and continue those efforts in understanding ventricular remodeling well. And in fact, it turns out that mechanical circulatory support provides us the best opportunity to do that. And in fact, the point is that we shouldn't put the cart before the horse in this situation, and that we need to continue to study this concept diligently, just as the group from Utah, led by Dr. Drakos and others, and your group are doing in a very diligent and informed manner for our field. Well, let me end with a few quotes. The first is that Louis Katz said this in 1966. He said the failing heart is not simply an enlarged version of the normal heart. You really need to look deeper. And this was at a time before they could look deeper. This was during the time when all they had was a hemodynamic model. And I show you this, most people are familiar with Normandy, the landing at Normandy. Very few are familiar with Operation Market Garden, which was actually a failed operation. This was really captured in the movie, the 1977 movie, A Bridge Too Far. And you have Gene Hackman and Sean Connery and Ryan O'Neal and others. in this movie. It's a fantastic movie. And in fact, what this was, it was planned that would be an airborne attack over the Netherlands, with the idea that 64 miles of territory would be captured, which included 9 bridges. And they were able to capture many of the bridges, but not the most pivotal one in Arnhem. In Germany, and that caused the operation to fail. And in fact, Lieutenant General Frederick Browning, who was also called the father of the British Airborne Forces, did say this. He said, I think we might be going a bridge too far. But even if we look at it pessimistically, I would like to end on an optimistic note that T.S. Eliot has said, that only those who will risk going too far can possibly find out how far one can go. Thank you so much for your attention, and I'll stop here, and hopefully we have time for questions and answers.
Yes, thank you very much, Mandeep. That was terrific, and I think it beautifully illustrates the field of heart failure, how you can go from cellular molecular mechanisms to LVADs, heart transplantation, and surgeries to try to rebuild the heart. And I just want to make one major correction. My involvement in the Restage Heart Failure study is only to be in partnership with Snehal Patel, who is the third author on that study and has been leading our efforts here for the past decade. And let me briefly, I think you met Mario Garcia anyway, our chief here, who's joining us now. Unless Mario has a question right away, I'm going to kind of go through the chat, as they call it, and start from the beginning with medical therapy.
Let me ask you a question before you do that, Mandeep. This was absolutely phenomenal overview, comprehensive. It's like I'm ready to take the boards in heart failure right now after this lecture alone. But I want to make a comment, and I want to hear your opinion. So, clearly the unloading of the left ventricle medically works, and to some extent, mechanical support, temporary mechanical support clearly also works. So I had 2 comments. If we believe on that, why shouldn't we reconsider the use of vasopressors of inotropic drugs when patients decompensate and go instead directly to transient mechanical support in those cases?
So Mario, I mean, great question, as I would have expected coming from someone of your stature. The bottom line is I completely agree that if you have an expectation that you will cause more toxicity with the use of persistent inotropic use, you should pull that back. And in fact, the field is moving closer and closer to more rapid mechanical unloading in the setting of acute insults. We tend to believe that in our field, the entire short-term mechanical circulatory support strategies in our field are now moving towards closer and closer implementation of mechanical support. In fact, the SCAI definition of cardiogenic shock is really an attempt to reframe our mind along the exact same lines that you have mentioned, Mario, which is they classify cardiogenic shock instead of making you visualize it as an extremis condition, which is how we've always visualized it. They classify it from A through E, starting with early stages of cardiogenic shock and giving you a chance to think about mechanical circulatory intervention earlier rather than later. I completely agree with you. The problem with that field, as you might imagine, is we don't have very good clinical trials to support that strategy. And the trials that have been done in such a way that those patients who do not have sufficient equipoise get removed from entry into the trials, which is why the only type of patients that enroll are those who are reasonably stable. And in those cases, we are unable to show a clear difference in outcome. If someone can think about a way of doing a clinical trial that actually enrolls the type of patients we want, the ones you've said, that'll be great. And Naveen Kapoor and his group have been thinking along those lines and have been thinking about creating the Unload trial, which is really designed to provide early mechanical intervention when someone comes in cardiogenic shock or in an acute MI, even before taking them for revascularization. And the idea at that point will be to really sort out what the contribution of acute hemodynamic unloading is over and above that of pure revascularization.
Wait, before I bring in Snehal Patel, who just joined, I just want to read from the chat from Shivank Madan, who sends his best regards and thanks for a great talk. So Snehal, as I mentioned, he's the director of heart transplantation at Montefiore, actually, and he's really the true expert here. I just do the moderation on recovery. So Snehal, if you have a comment or a question, that'd be great.
Oh, before Snehal, you ask the question, let me apologize. Since Uli corrected me, I should have been much more clearer in recognizing your incredible accomplishments and having seen all your wonderful work submitted to JHLT when I was editor of that. I stand absolutely corrected.
In Montefiore, we express our apologies in Brunello units. I'll get back to you later on this. Snehal.
Well, first of all, Mandeep, thanks for an incredible talk. And, right before you got on, Uli had sent an email to the faculty saying, please, everybody join. He's an exceptional speaker and probably the best I know of. And I think this just validates it. A field that I think I know everything about after listening to your talk. My mind's spinning with different insights and perspectives. One thing that really struck me was the figure on elasticity versus plasticity. And this is a little bit more hypothetical and kind of goes along the lines of what Mario was talking about in chronic heart failure. If we can figure out ways to really quantify that, where are we in terms of designing a trial where we institute durable MCS early to actually promote recovery in less sick patients? And do you think that's realistic with the current risk profile, or do you see it happening in the future?
So Snehal, a wonderful question. And what I would say to you is that this was exactly the line of questioning that I was hoping to achieve from the talk. Right. So when I started the talk, I said, I'm just hoping that you will ask me the question that I'm hoping you will ask me, and you just did. So if you just think about the restage trial, which you were a great part of, even though you were so selective, your criteria of selecting into restage still resulted in a flip of a coin response to explantation. Okay. Yeah. Which means that the question you're asking is, how do we get smarter? How do we figure out who is going to retain deformation memory and who isn't, or who's actually going to be able to get closer to that elastic region? And I think that some of this may have to go even further. If you have time in chronic heart failure, I think understanding the microvascular flow in these patients on optimum medical therapy could be a very key component to understanding which patients have the true potential for recovery and who don't. Giving people the opportunity of MRI to see how much scar formation there is in the heart and degree of fibrosis, perhaps biomarkers of fibrosis or a combination panel, may be the way to go in these patients. Maybe the right signaling for deformation memory might be mRNAs, microRNAs that circulate and give us insight into that. So I think the next step needs to be to develop a panel of biomarkers that take us one step beyond young age, non-ischemic cardiomyopathy, and recent onset of heart failure into understanding cellular principles a bit better with biomarkers. I don't know what those markers are going to be, Snehal, but given your astute contributions to the literature, maybe you and Shivank and Uli can find out.
We will try. So let me fire a few quick questions here. Francesco Castagna is one of our fellows who will go into heart failure also, has actually a great question, which is the time to place the inflow cannula somewhere else. This is in response to your APEX explanation.
Yeah, so I'm a fan of the APEX, as you've seen. I think the APEX is so important that you should avoid the APEX during an LVAD implant at all costs if your intention is myocardial recovery. Okay, if your intention is myocardial recovery. If it isn't, then it doesn't matter. then put it in. If you're going to bridge somebody to transplant, you've decided that, no worries. But if you want recovery, you're going to have to not put it in the apex. The apex, I mean, now I can go on and on, but take amyloid. Why is there cherry on top on imaging with amyloid? Even in amyloid, the apex gets spared. Think about it. It's a unique area of the heart. So Bud Frazier and his colleagues at Texas Heart have actually proposed this. We published this paper almost a decade ago in JHLT, where they in fact suggested a non-apical positioning for the VAD, where the inflow was still directed towards the mitral valve, but avoided the apex and was more diaphragmatic in position. And in fact, it's my understanding that the concept behind the creation of the HVAD was exactly that you would avoid the apex. I think what happens in reality is that by the time we take these patients for an LVAD, it's such a globular heart that it's hard to, first of all, exactly detect the apex. I mentioned this at a discussion we were having internally on momentum, and all my surgical colleagues laughed at me, said that's because you don't know. We just put our finger in there and we can feel the dimple. And I'm like, okay, well, if you can feel it, then avoid it, is what I would say. So I completely think that new strategies for implantation of VADs that are non-apical must be considered. And it's worth testing.
Great. Excellent. So I'm looking at, I have this little YouTube warning light flashing that we have an hour, so it's up. So again, on behalf of all of us, I just want to thank you for joining us, and you will not get away with this and not coming in person as soon as the COVID epidemic ends, and we can have you down here at Montefiore again. Yeah, so Mandeep, thank you so much. This was terrific, and I hope to see you soon.